I'm called Sister Dr. Nalubega Florence, a gynecologist who has been here as a gynecologist since 2012. Although I was here as a medical officer in 2007, and I took part in different types of camps where I found that it was so interesting, challenging, and at the same time interesting. It really helped me to pick up different skills and also to have more interest in preventing damage of the ureters, which I got more when I finished my master's during the camps. In the 4 camps, we have been with different surgeons from different areas with different skills, and this has, as I'm standing, it has helped me so much to gain courage in management of fistula. At least I've taken part myself in doing the different types of fistula, and rectovaginal fistulas and vesicovaginal fistulas, the simple ones. And because of this interest in the management of fistula, I also got chance to go to Ethiopia, where I got a training for 6 weeks, which was so interesting. It helped me to at least to compare the different challenges the mothers in Uganda get and the mothers in Ethiopia get, and also to know more about the different causes of fistulas and what the countries at large can do in prevention of fistula, what the paternal side, like the husbands, can do in prevention of fistula, what the community members can do in prevention of fistula, especially in realizing how to refer the mothers early. Because in Uganda, the problem we find out that most of the mothers are deliver at home. Some of them deliver with the traditional birth attendants, and then others find themselves in health centers where the nurses could have a little experience, and they take long in referring the mothers to the hospital. But all this, we had to get that light when we came in fistula management, because we took part in taking the history and seeing the challenges of these mothers, the duration they take on their way to the hospital, the 3 delays in the community, 3 delays in the health center, another delay in the health center, and delay in the hospital in this decision making. So all that has been very good experience, very good challenge, so that to improve on my skills and to improve on the way in the interest in management of these mothers. Yeah, in the past, really, the government didn't know much about fistula. Even us in our training, we used to take it as a by the way. We could go and know that now we have to manage it, we have to know something about fistula. But we really didn't know the details, and we really didn't know the extent of and the population which has the mothers having fistula, that they even reach up to 2 million. So we really didn't know, and we didn't know the challenges of this mother. Not until we started at least talking to the government, talking to different leaders in the community, leaders in the church. That's when we realized that there are very many mothers in the community. And even these different groups, like for example, the community leaders, have helped us a lot in gathering these mothers and bringing them out, and also reintegration. They have done a very big work in reintegration of these mothers, because when they get the fistula, they now become intimidated. They don't want they are hated in their homes. They are sent out from their families. They are separate. They separate from their husbands. So reintegration becomes a big problem. But as the government, the community leaders, the religious leaders have taken part, it has made it easier for integration. It has made it easier for us getting mothers for treatment. Yeah, because we do it really, we go to the communities prior to the surgery, And when we're in the communities, we don't do it ourselves. We do it with the health workers in the health centers, and at the same time, the community health workers we find in the community, the LCs, and then we go to the churches and we talk to the people in the church, in the mosques, and then we found out that we increase in the number of the mothers coming in the hospital. Then the other thing, we also use radios, televisions, NTV, like NTV in Uganda, we use UBC, we use all those ones so that at least people can now know. Then we also have charity walks, so that in the charity walks, mothers come to us, they ask us questions. Then sometimes we make outreaches, and then we examine them from there. We screen the mothers and then bring them to the hospitals by using either public means or a taxi. Yeah.